Good evening, everyone. Today, on behalf of Kahu Diagnostic Division and on behalf of our President, Dr. Seema Bhargava, and Secretary, Dr. Aparna Jairam, I would like to welcome our distinguished speaker for the day, Professor Dr. Meherbano Kamal. Ma'am is a renowned pathologist and has been in the field of pathology for the last 36 years. She has been a postgraduate guide for more than 29 years and trained in cytopathology from the #1 institute in the country, that is AIMS, New Delhi. She has been past president of Indian Academy of Cytologists and national editor for Acta Cytologica, again a very renowned cytology journal. She has more than 35 publications to her credit and has been editor of monograph in Atlas, Uterine Cervix Cancer and the Bethesda System. She has also contributed chapters in various textbooks and has received research grants for cervical cancer from ICMR, Chitnafis Trust, then Inclin from Philadelphia, US, and ICMR. She has been convener of national and state level conferences and faculty for government recognized courses as well, has been quiz master for many conferences, MapCon, VAPM, then UG quizzes. She has received many awards, national as well as state level, and also has done many international presentations also. And her paper presentations have been rather more than 60 till date. So it is indeed an honor for all of us to hear what ma'am has to say for today about pap smear and the challenges in interpretation. What we all have daily in our routine practices, we have some challenges. There are some cases which really make us think out of the box, and let us hear from ma'am, because experience is really what makes a huge difference. So ma'am, I welcome you to this platform and waiting to hear from you.
Thank you, Preeti. And at the very outset, I would also like to thank Kahu and the complete team for considering me for this talk on your platform. I find this very interesting. This is my first time when I've been closely associated with this platform. And thanks, Preeti, for the very kind introduction. I really do not deserve as much, but I'm definitely very sure that I'm very passionate about teaching residents, postgraduates, post-MDs still, even after my retirement. Thank you so much. So should we start with the talk? So after this brief introduction, I will today be dealing with pap smear challenges in interpretation. And my focus would be on the defining the undefined squamous cells, that is the gray zone lesion that we encounter in the cervical cytology. As a disclaimer right in the beginning, the source of this lecture material is the Bethesda System, primarily by Ritu Nair, Wilbur, and David in their 2015 edition, and my own book on uterine cervix cancer and the Bethesda System, published in 2022, just last year. All the cytology pictures of pap smears, liquid-based cytology, biopsies, and the colposcopic pictures are from my own material, taken during the screening camps, and slides that come to me for consultation, and also the colposcopies that I do myself. I have those pictures with me. Thank you. Now, friends, any talk in gynec cytology is incomplete without paying tribute to Dr. John Nicholas Papanicolaou and his wife, Andromache Mavrogeni, who gave this couple gave birth to cytopathology as a subspecialty of pathology. And this scientist couple was bestowed with many awards and accolades for their untiring efforts in this field. But the highest honor came in when the scientific community at large decided to name the cervico-vaginal cytology as the pap smear. Now, not only the pap smear, but also his reporting categories, that is the classes 1 to 5, were adhered to for almost 4 to 5 decades. Now, as our understanding of the pathogenesis of cervical cancer and its precursor lesions improved, the two-tiered morphologic classification of the Bethesda system came into existence. And this classification has been based on the realization that LSIL and HSIL, that is low-grade squamous intraepithelial lesion and the high-grade squamous intraepithelial lesions, revealed different pathogenesis totally. And it became very clear that uh, LSIL is generally caused by low risk viruses, that is 6 and 11 types, that replicate extra chromosomally utilizing the machinery of the mature squamous cells. The virions, they replicate here, they are disrupted, and then they replicate, and once they finish their job, they cause the clinical lesion. They are once again assembled to complete virions, and they are released onto the surface. Now, so LSIL is simply a productive viral infection in which the virions are subsequently packaged with the capsid proteins into infectious virions ready to infect others. Now, such lesions do not necessarily lead to CIN2 or HSIL. On the other hand, in some women, especially those infected with HPV types 16, 18, 45, there is integration of the HPV DNA into the host chromosome. Now, this integrated HPV gene, as you can see here, the red part is the HPV virion. It has integrated into the host genome. It results in deregulated expression of the envelope proteins, that is the E6 and E7, which interact with the cellular regulatory proteins like the P53 retinoblastoma protein, P21 MCM, JUN, etc. And this leads to immortalization of the cell. So they go on replicating relentlessly. And this is how you get high-grade lesions. I have separated the two on the screen very clearly to show you that LSIL is a productive infection, and this is a more ominous infection which leads to higher grade lesions, that is the CIN2, CIN3, and probably invasive cancers. Now, the success of a pap smear as a screening test is heavily depends on mastering the technique of collecting a cervicovaginal smear. Although this is the domain of the gynecologist, we as pathologists, and most of us are ladies, can also become can master this technique very easily. Now, a cervical smear adequately collected from the squamocolumnar junction and the transformation zone, as you can see here, is still a very simple, economical, and convenient method for the detection of the crime committed by this HPV virus. Now, a variety of spatulas, brooms, brushes, and swab sticks are available in the market to adequately sample the squamocolumnar junction and the transformation zone. Now, no matter whichever device we use, the commonest condition that we are required to sample, at least in the developing countries, is the inflamed cervix. And 70 to 80% of the smears in our reporting trays are inflammatory smears. You will agree with this. Now, today, more often than not, a variety of pathogens can be detected in these smears. Like here, you can see the clue cells of the Gardnerella vaginalis, the Trichomonas vaginalis, and you have this shish kebab appearance because of the skewing up of the squamous cells on candidial filaments, and then you have this HSV infection. Anyways, my today's focus is not on how to identify these infections. Rather, what do these infections do to the epithelial cells, which lead to creating dilemmas regarding reporting epithelial abnormalities? That would be my focus. Now, the epithelial cells in an inflammatory smear by and large are unremarkable. As you are seeing here, this is a liquid-based preparation, a clean background, uniformly distributed cells, and as against these conventional pap smear, here you have a dirty background. There is a lot of inflammation overlapping these squamous cells, which sometimes really makes it difficult to interpret the cellular features. And then you are really in a dilemma what to report them. Now, actually, by and large, as I told you, the cells and the nuclei are normal, but the troubleshooting starts when, as a result of long-standing infection, there are reactive cellular changes in the form of significant nucleomegaly and hyperchromasia, binucleation, and then you fall into the trap whether to report this as RCCI or as atypical squamous cells. Here, as you can see, there is some amount of hyperchromasia, there is binucleation, slight enlargement of the nucleus. Even this nucleus is slightly enlarged, but the boundaries are very smooth. There is even distribution of the chromatin. Here again, you will see some amount of cytomegaly, nucleomegaly, and in this field, you are seeing a lot of anisonucleosis and varying sizes and shapes of the nuclei. But still, all these features do not uh, are not confirmatory of a LSIL. And then you tend to report them as ASK-US, that is atypical squamous cells of undetermined significance. Now, an over-interpretation of ASK-US, I must emphasize that this category is not a waste paper basket. You have to use it very carefully. Now, in this smear, we'll just take the history of this patient. She's 39-year-old female with a long-standing discharge. What you can see here, you are seeing large mature squamous cells with an enlarged nucleus. If you compare the size of the nucleus, it is around up to 3 times the size of the nucleus of an intermediate squamous cell. Here also you are seeing pretty many nuclei. When this change is generalized, and you see these smooth boundaries, even distribution of fine chromatin, but you find that there is nucleomegaly, but not reaching to the criteria of LSIL or ASQ-US, you are in a dilemma. Now, let me tell you that when you want to report it as ASQ-US, the nucleus size should be 2.5 to 3 times the size of an intermediate cell nucleus, and the size of intermediate cell nucleus is around 8 to 10 micron millimeter. But here you are seeing some amount of hyperchromasia, but sometimes you can even get hypochromatic nuclei, but the even distribution of the chromatin is very obvious in these pictures. And so in such smears, you can safely report them as NILM. Now, let me tell you, the complete Bethesda system and the concept of cervical cancer is based on detecting epithelial abnormalities. You may detect a lot of infections, some interesting findings, or some pathogens. That is all apart, but you are supposed, the pap smear is supposed to tell you whether there is an intraepithelial lesion or not. Or in other words, is there any dysplasia or not, or any CIN 1, 2, or 3 or not. So if you are very clear it is not there, Bethesda system makes it very mandatory to write in the report that there is no intraepithelial lesion or malignancy. That is mandatory to mention in the report. So you can report this particular smear as NILM. But when you come to this type of a smear, what you are seeing here, there is more hyperchromasia. Here there is binucleation, there is uneven distribution of the chromatin. If in all the 4 quadrants of the nucleus, the chromatin is stippled, and the salt and pepper type. And here you can see some amount of nuclear membrane abnormalities. So all these features now, they are slightly beyond reactive cellular changes. And now, should you report this as ASQ-US or LSIL is the dilemma in your mind. So what would you like to do in such situations? We have 3 options. If you are in a situation where there is a hierarchical review facility, you can take multiple opinions from trained cytotechnologists, from your colleague pathologist, and form a consensus opinion. Or secondly, you can dig into the clinical details of the patient, go into her previous PAP reports, whether HPV test has been done, and what are the reports. If there is a history of multiple prior NILM smears, and recently done high-risk HPV DNA test is negative, then in that case, these features are unlikely to be, all these features are unlikely to be ASQ-US, belonging to an ASQ-US category. The third option that you have is a repeat after treatment of infection. If you are sure that your patient is going to return back to you, you can call her after 6 months, give her a good course of antibiotic, and then in the majority of the cases, there will be reversal of the reactive cellular changes, and you will be very confident. And if at that time these abnormalities still persist, and if a HPV DNA test has not been done, you can advise HPV DNA test for high-risk viruses. Now, when do we report atypical squamous cells? Now, this is the Bethesda category which has been retained even in the 2014 classification, and there is a binary classification to this, ASK-US and ASK-H. Now, what is very typical of this atypical category? First thing is that there has to be squamous differentiation, there has to be increase in NC ratio, and minimal nuclear abnormality should be present to call the cells as atypical squamous cells. Now, if the nuclear changes that you are seeing are present, are equivocal, and that is qualitatively and quantitatively they are insufficient for a definite interpretations, then you can label the cells as ASQS. We'll just see a few examples. Like in this, you are seeing multinucleation, but are you sure the two nuclei out of the two nuclei are not being reflected from the cells beneath the cell which is lying on the top? So because of the transparency of the cytoplasm, sometimes you tend to overinterpret binucleation and multinucleation. And if suppose such type of cell is just a single feature that you are seeing in the smear, then quantitatively you're falling short of abnormal cells. Again, sometimes you get such cells which are large and show a smudgy nucleus, and then you cannot interpret the quality of the chromatin to give a definite report of LSIL. Now, in this smear below, this is an out and out lesion of LSIL, and the nucleomegaly is far beyond 3 times. It is up to 4 to 6 times the nuclear enlargement is there. There is even cytomegaly, which is a very characteristic feature of HPV infection, and you have coarse chromatin unevenly distributed in all the 4 quadrants, and you have a nucleus occupying almost 50% area of the cytoplasm. There is hyperchromasia, finely speckled chromatin, and membrane irregularities also present. So this one is an out and out LSIL, and on the top 2, if these cells are less in number, you can call them as ASK-US. Now, this is a clinical lesion which is showing a dense aceto-white lesion, and the margins are very sharp, and these are LSI lesions that the colposcopist is seeing clinically. Now, there are other features in the smear that cause troubleshooting. When you see such dyskeratotic and parakeratotic cells and such anucleate squams in the smears, these generally come from the surface of benign warty lesions. So what are parakeratotic cells? These are mature superficial cells which have, they are shrunken and they are keratinized, and their nuclei are very tiny with smooth margins. So this is a normal reaction to an inflammation which is going on for a long time in the cervix. These are the dyskeratotic cells, and what are these? These are deeper cells, parabasal type or basal type with keratinization and dense hyperchromatic nuclei. And then you have these anucleate squams. So all these features sometimes can be present in the smear, but if these are all typical, you are very sure that this is because of inflammation. But the trouble starts when you have atypical parakeratosis. Like you are seeing in this smear, the nuclei are slightly larger, they are wavy, and all these cells, they are compressed, condensed, and keratinized, and they have snake-like nuclei or spindle nuclei. Sorry, these are dyskeratotic cells. They are more round to polygonal, keeping to the configuration of parabasal basal cells. Now, we know that there is an entity known as the keratinizing dysplasia, where you cannot categorize the entity into LSIL or HSIL. It is just keratinizing dysplasia. And so we know that once keratinizing dysplasia is present, beneath this epithelium, you can have these ominous lesions of CIN2 and CIN3. Again, these are the dyskeratotic cells. So all these types of features can camouflage a worser lesion beneath it. And that is why long back there was a concept of doing 2 consecutive smears, so that you scrape off all this material and try to get it on the smear, and maybe then you'll get some cells from the deeper or high grade lesion. but currently that is not so. Now, what do you do when you see such atypical parakeratotic cells and dyskeratotic cells? Should you report them as NILM? Definitely not. Should you report it as LSIL? Now, in the absence of classical koilocytes or cells of LSIL, you cannot report it as LSIL2. Now, if not liberal, a judicious use of the category of ASK-US as a diagnostic category significantly improves the clinical usefulness of the PAP test. And like in this biopsy, the atypical parakeratotic layer may camouflage a more ominous lesion, as we saw in the last slide also. And then if you report it as ASK-US, you're going to give benefit to the patient of being of undergoing complete workup in the form of a colposcopy or HPV DNA testing. So this is the concept. So it's better that you report it as ASK-US. Bethesda system allows you to do that. Now, if there is excessive reliance on the presence of koilocytes as a sole diagnostic feature, then HPV infection may be missed on cytology in around 15 to 20% of the cases or the smears. Now, factors which interfere with the maturation of the cells like ossipals, women taking ossipals, inflammation or epidermal atrophy may result in absence of koilocytes, because we know that koilocytosis is a feature of mature cells. So if the epithelium is not maturing, you may not get that frank features of koilocytosis. Now, in that case, recognizing and reporting any two of these features like cell plaques, hyperkeratosis, parakeratosis, dyskeratosis increases the sensitivity of cytologic diagnosis of HPV infection, and then it can be triaged with HPV DNA test. And we know that these rafts and pearls and the this keratin which is coming here and comes from the surface of the warty lesions or leukoplakic lesions. In all such patients, HPV DNA is positive in 40 to 50% cases, and reflex HPV DNA testing provides a safety net against false negative cancer screening results. Now, till now, we were seeing that the nuclear features or the nuclear atypia create dilemmas. But one more feature that is a troubleshooter in the is the incomplete or partial incomplete koilocytosis, poorly defined cytoplasmic halos, and cytoplasmic vacuoles. Now, the cytoplasmic clearing or haloing that is suggestive but not diagnostic of koilocytosis is encountered in number of situations in inflammatory smear. Now, here you're seeing a cell plaque and there is some amount of vacuolation around the nucleus. But the area of clearing is very small, and the nuclear atypia is there. There is slight increase in NC ratio, but the nuclear atypia is not that bad. So in such cases, you have to remember that there is a big list of differential diagnosis of the perinuclear halos or pseudokoilocytes that we call. The first and the most common one is that of the navicular cells. These all three are examples of navicular cells or the intermediate cells which are laden with glycogen under the persistent stimulation of progesterone, and they give a feeling of clearing of the cytoplasm, but there is no definite wire looping and there is lack of atypia. Even if there is some amount of binucleation, the nuclear atypia is not as much as compared to all these examples of koilocytes that I have put in the slide. Now, the other very common cause of hallowing around the nucleus is the trichomonas vaginalis and the candida infection. Now, in the slide, you can see the nuclei, they are surrounded by small halos. Now, the trick halos, these are called the trick halos. These trick halos are very tiny. They just occupy 1/3 area of the cytoplasm, whereas for a classical koilocyte, you need the halo to occupy more than 2/3 area of the cytoplasm, and it has to be optically clear. The margins of the koilocyte, they have to be very, the halo have to be very sharp. Here you can see a very ragged margin in this, it's very clear. These are the trichomonas bodies. Here again, you have these candidal filaments, and this is a metaplastic cell with two-tone cytoplasm, a dense periphery, and a paler endoplasm, which is giving you a halo effect. And another clue to all this is that there in TB infection or trichomonas infection, this change of perinuclear haloing will generally be seen in most of the cells. It is a uniform appearance in all of the cells. So such thing does not happen when you have true coilocytes. Now here you are seeing some amount of vacuolation of the cytoplasm. There is no doubt binucleation, but the nuclei are absolutely normal. So this is also again a pseudocoilocyte. Here there is ballooning degeneration of the cytoplasm, but the nuclear ATPI is not as much. So these are all examples of pseudocoilocytes. Now, vacuolar degeneration, another example. Here, when you have this bloated cytoplasm, the nucleus is also degenerated. It is pale and it's almost on the verge of disintegrating. Metaplastic cells, as I showed you before, these are very typical, and they are known when they are maturing, they are acquiring the glycogen, and when they are becoming intermediate and superficial in nature, they are acquiring glycogen, and at this stage then you have a dense ectoplasm and a pale endoplasm, which gives them that a halo-like appearance, and these are all pseudocoilocytes, as against these that I'm trying to show you: binucleation with abnormal chromatin, multinucleation, cytomegaly. So I'm sort of repeating my features so that it becomes very clear to all the newcomers here how you have to report them. Now, as per the Bethesda system, low-grade squamous intraepithelial lesion encompasses both HPV infection and CIN1 lesions. Although the coilocyte is the hallmark of HPV infection, one must understand that even CIN1 lesion is induced by the HPV virus or the high-risk HPV virus, or maybe low-risk, but it takes a morphologic backseat after inducing the lesion. So once the lesion is formed clinically, not necessarily you will get coilocytes, and these are the lesions that come under the category of CIN1. Now, these are the cells coming from CIN1. They have similar features, cytomegaly and nuclear features. Everything is same, but the smear will not show you the classical coilocytes. So in the absence of classical coilocytes, it is almost impossible to differentiate HPV infected cells from cells originating from a CIN1 lesion on cytomorphologic grounds alone. And this is the reason why HPV and CIN1 have been clubbed in LSIL. And this distinction, really speaking, is no longer meaningful clinically. The management remains the same. Now coming to the other category, that is the atypical squamous cells cannot rule out high-grade lesion or ASC-H. Now it is very common to see metaplastic cells in an inflammatory smear. And why? Because we as pathologists know that inflammation and repair go hand in hand. The process starts immediately. The process of repair starts immediately whenever there is a long-standing infection. Now, and when you have repair, you have metaplastic cells in the smear. But metaplastic cells at times make you stand still on the crossroad when they are not very typical. What you are seeing here, these are maturing metaplastic cells. They have looking more. They have a cytoplasm which is keeping, which have the qualities of intermediate squamous cells, but it is still dense. There is enlargement of the nucleus, there is hyperchromasia, binucleation, and these are looking slightly atypical. But would you like to call them cells of HSIL? No. Now, these are the other picture is showing these parabasal type of cells or the metaplastic cells. Here you have a higher NC ratio. The nucleus is occupying more than 50% of the area of the cytoplasm. Again, here in these are all maturing metaplastic cells with atypical nuclei. So now in such cells, what are you going to do? Now, there are situations when you have such disorderly clusters and sheets of cells or syncytial clusters with anisonucleosis and worrisome atypia. Now, but these the chromatin in these nuclei is also looking a little bit coarse, but it is evenly distributed. The boundaries of the nuclei are very smooth, and you can see prominent chromocenters, and sometimes you can see even nucleoli. Now, this the chromatin, which is fine to coarse and evenly distributed with modest nuclear prominence, these are all atypical immature metaplastic cells as a result of reactive and reparative changes. Papinicolo had his class 3 to 4, which was totally dedicated to with atypia, dedicated to atypia associated with repair. And this is what we are facing even now, but the terminology in reporting these cells has changed. Now, and the presence of inflammatory cells mixed with these atypical metaplastic cells is a clue that this is an inflammatory process, and then you can be very safe in reporting this as NILM. But as against these cells, now these are again metaplastic cells, and they're very immature, but see that NC ratio is high, hyperchromasia is there, and but still I would say that this is a flat sheet, it is not a syncytial cluster, and each cell has a very nice boundary. So, but here you have a dyskeratotic cells. Keratinization in any form is not acceptable in a smear. When you see even a single keratinized cell with abnormal nucleus, it should alarm you and come up of the patient. So it is HSI. Again, in this lower picture, what you are seeing is a high NC ratio, abnormal nucleus, hyperchromasia. But these cells, they are not those of HSIL where they are present in syncytial clusters. They are smaller, they are rounder, and they have less amount of cytoplasm, and they have pretty many nuclear membrane abnormalities which are missing in this. So would you report these cells as NILM? This I'm referring to. Definitely not. Neither it is RCCI nor you will report it as NILM. Should you report it as HSIL? Now, if you compare this smear with this classical HSIL, you will see that the NC ratio, the size of the nucleus should be 4 to 6 times the size of an intermediate squamous nucleus. There have to be a lot of nuclear membrane irregularity, dense hyperchromasia, bulbous protrusion, and the cells are really smaller, rounder, and parabasal type. So you are not in a position to report this as HSIL. So should you report it as H? I think that is a category which is much safer for you rather than going overboard. Now this, as I've told you, the cells of HSIL, they are of the parabasal type, and they have a decreased amount of cytoplasm. The nuclear size is 2 to 5 times the size of an intermediate cell nucleus, and the nucleolus is also absent. So in such cases, you are safe in reporting as H. Now, these cells could be coming from a CIN2 lesion. When we had when we did not have the category of HSIL, which encompasses CIN2 and CIN3, we used to do hair splitting. So these cells could be the cells of CIN2 because there is more abundant cytoplasm and more mature cytoplasm. But now when you have only one category of HSIL, you have to take a decision this way or that way, whether it is HSIL, yes or no, or if you want to put it in the H category, that is more comfortable to you. And these are the diagnostic challenges that you generally face in reporting inflammatory smears. Now, atypical squamous cells cannot rule out high-grade lesion, that is the H category, has many differential diagnoses, or the cells are many that show similar features. We'll just take them up one by one. But let me tell you, around 10% of all the lesions belonging to the ASK category are ASK-H, in which the cytology changes, cytologic features are suggestive of but not diagnostic of HSIL. Coming to these, now in liquid-based preparations, you have such single cells coming more commonly in the smears, and then it's very difficult to, these cells are very round, you cannot assess the NC ratio. The rounding up of the cells is because the cells are lying in a liquid medium and they do not flatten so easily like the cells in a conventional smear flatten out very nicely. So again, when you see such cells and there are very few of them, you are in a dilemma and you want to report them as ASK-H. Now, sometimes in conventional smears, also these are example of conventional smears. You have these small single cells with high NC ratio, round nuclei, and some keratinized cells that you are seeing over here. Here again, you have a single cell hiding behind all these mature squamous cells, but the nuclear membrane is very abnormal. There is a bulbous protrusion over here, and there is even binucleation of this cell. When such cells are very few, so the definition applies qualitatively or quantitatively insufficient cells, then you can label it as ASK-H. These cells that you are seeing, the tiny cells that you are seeing, are also known as the litigation cells, and they have been picked up by rescreening or by automated devices in the West, and therefore automation and artificial intelligence has gained tremendous popularity these days. Now, remember that ASK-H reports are not triaged with HPV DNA test. The patient straight away goes to colposcopy. Now, atrophy is another situation in which the epithelium is very thin and you are scraping out all the parabasal type of cells. So here you have a sheet of parabasal cell, which is a flat sheet. Remember, it's not a syncytial cluster. Although all these cells are appearing uniformly hyperchromatic with a high NC ratio, these cells cannot be qualified as cells of HSIL. But still, you have lingering doubts, and then you can report it as ASK-H or recommend a repeat smear after application of estrogen, wherein you ask the patient or advise the gynecologist that she applies estrogen for around 2 to 4 weeks and then comes for a smear. And then the hormonally deaf dysplastic cells will stand out very clearly in the background of mature cells. This dilemma of atrophy is sometimes not solved even with biopsies, and then you have to resort to P16 staining to know whether this is a true lesion or this is simply a reactive lesion. Now, sometimes SIL, that is squamous intraepithelial lesion, grade cannot be determined. Now, this has been permitted in the Bethesda classification, that if you are unable to decide whether this is LSIL or HSIL, you are not able to decide, and this generally happens with HPV infections where there is excessive proplastic effect. When the virus is multiplying a lot and then the nuclei are proliferating, you have very huge nuclei, and then you cannot gauge the maturity of the cytoplasm. You feel that this is all high NC ratio and these are all syncytial clusters of HSIL. So this is the exuberant response to the HPV infection sometimes leads to this dilemma, and you are unable to decide the grade of the cell. In that case, you can simply report it as squamous intraepithelial lesion. Grade cannot be determined. At times, here, like in this, you can see there is the cytoplasm is very mature, the cell is large, the nucleus is also very large, but because of the maturity of the cytoplasm, you are unable to decide whether to put it in the category of LSIL or HSIL. And then I think still grade cannot be decided, can be a better option. Now, the other area which is very problematic is the hyperchromatic crowded groups, which is the second type which gives you the dilemma of whether this is a HSIL or this is simply ASK-H. Now, what's happening here? You are seeing a cluster of small round cells. You don't know what is whether these are glandular or whether they are squamous or whether they are parabasal. Focusing cannot be done. They are thick clusters, like here again you are seeing. Now, in this situation of hyperchromatic crowded groups, when you are unable to decide the type of the cell, glandular or squamous, and the nuclear qualities, you can report them under the ASK-H category. But this has to come a little later after you have analyzed enough and you have studied the cell clusters meticulously and tried to decide, yes, this is glandular or this is squamous. So what are the clues that they are belonging to coming from a squamous lesion, these clusters? And sometimes you have very nice anatomic margins, and inside the cluster, when you do up and down focusing, you can see whirling and swirling of these cells, and that is a clue that these cells are coming from a squamous lesion. But like in this, you have some vague acinar arrangement over here, and this is a loose cluster with very wispy cytoplasm here and there. Then you feel that this is coming from a glandular lesion or higher up from the canal. These cells are much smaller, but I think they are more of the basal type. And then again, if you are not able to decide their origin, you can report it as hyperchromatic crowded group seen, and the report will be ASK-H, colposcopy, and further workup is advised. Now, with a lot of brooms and brushes coming in, sometimes you tend to enthusiastically collect cells from the canal. And when the lower uterine segment is very small, you try to pull out cells from the lower uterine segment, and then you get such endometrial cell clusters. Why I'm calling these endometrial cells? Because they are very small cells. They have these contours and very thin nuclear membranes, but of course, still you cannot be very sure whether they are endometrial, endocervical, or the small cell type of HSI. Again, in this field, you are seeing such clusters of cells where it's little difficult to decide whether they are squamous or they are glandular, whether or not they are neoplastic or non-neoplastic. So in such situation, ASK-H is an appropriate interpretation. Now, friends, who is responsible for all these gray zone lesional dilemmas? Really speaking, the problem is not of the reporting cytologist. Don't bring the guilt on yourself. But by and large, the problem is with the lesion. And just like we are faced with such gray zone lesions, even the colposcopist is all faced with such borderline lesions. When there is repair, you have dense acetovite areas, and you have acetovite areas around the opening of the glandular crypts, and then you have equivocal villi findings, equivocal VIA findings, and then they go on taking punch biopsies and smears from these lesions, and then our gray zone becomes wider, and we come across all these uh, cells in our reporting trace. As against these very clear-cut out and out lesions, all these are gray zone lesions for the colposcopist. Now, just coming to the carry home messages that I would like to bring to you or to your notice, the atypical squamous cell category is not a problem of our gray matter, I should say that, and it is not a single biologic entity either, and the changes unrelated to HPV infection and neoplasia are also included in this category. Then there are many non-neoplastic conditions which can cause atypical squamous cells, like we have seen before: inflammation, atrophy, degeneration, air drying artifacts, etc. And HPV DNA, a positive HPV DNA test is found in 40 to 50% of cases that are labeled as atypical squamous cells. Now, when you have this ASK category, 80 to 90% are ASK US. What is the further action? Repeat cytology at 6 and 12 months, and or do a reflex HPV DNA test. 10% of them are ASK-H. The next step is colposcopy for them. And also remember that this atypical squamous cells become lesser and lesser in number. They decline in number with increasing age of the patient. So taking into account the clinical picture of the patient, her age, her menstruation status, and how many smears have been done in the past, all this can help you to come to a logical conclusion. Now, in order to increase the sensitivity and the diagnostic accuracy of the pap smear, quality control measures should be followed in all the labs as a part of quality assurance, and this can be achieved either by doing a review by second cytotechnologist and or cytopathologist, calculation of the ASK-US and SIL ratio. This should not exceed 3:1 by any cost. And continuously you should take all efforts to correlate your ASK-US findings with positivity for high-risk HPV test, and also take all efforts to correlate ASK-US cases with the results of colposcopically directed biopsy. I understand this is easier said than done, but if you have to run a laboratory with good quality reporting, these efforts have to be put in. Now, as I've already told you these points, just remember very clearly, ASK-US category, you have mature or mature metaplastic cells. For ASK-H, you have immature metaplastic cells. The risk of HSIL when you are reporting ASK-US is 18%. And when you are reporting it as ASK-H, the true HSIL will be seen in 45% of the cases. And according to the IELTS study, 50% will be high risk HPV positive, and here you will have 30 to 40% patients who will be positive for the HPV DNA test. And you know the further action I have already told you. Thank you.
I think that was a beautifully illustrated and comprehensive lecture, ma'am. You are an expert in this area, and it was evident in your slides how much of experience has gone in this. And it was beautifully covered all the limitations, the advantages, and what exactly we have to see under the microscope, and what are the pitfalls that one should be guarded against, because you don't want to give a wrong diagnosis leading to unnecessary colposcopy and biopsy. So it was very beautifully illustrated. People, please put your questions in the chat box. I can't really see any question. One, Anushri has asked, please throw light on EQUAS in pap smear.
Yes, external quality assurance program is being run by the Indian Academy of Cytology, and you have to join this EQUAS program, and you go to the cytoindia.com site, and you'll have the section of EQUAS. And if you join this, pay the necessary fees for this, your institute will get regularly a set of slides of cytology, which will have both FNAC and pap smears. And then you have to give them back the diagnosis, and then it is properly analyzed during the annual conference. So this is a very regular feature, and Dr. Radhika Srinivasan and Dr. Nalini from PGI Chandigarh have been running this EQUAS program for a very, very long time. It's worth taking, investing time and money in this.
Ma'am, could you also just highlight the internal quality control, which you very beautifully highlighted? I think people want to know a little more, because this is one area people are not really aware about. So a few parameters that one would assess the quality of reporting of pap smears.
Yes. Now, the first thing when you want to really give a good and correct report to the gynecologist, your equation with the gynecologist has to be very friendly. Do not hesitate to talk to them in case of a smear which is abnormal. Do not, because we barely get the details on the clinical form. Like they do not even tell us. They will definitely write that she's a female 40 years, but they won't write what is her clinical findings. We know that pap smears come from female, so it's so funny sometimes. But then you want to know more details, whether there is clinically there is an erosion or not, whether she's bleeding, or what is her LMP. So for all these details, you need to contact your gynecologist. This is one thing. Now, once you get this information, it becomes very clear to interpret the smear. Some of your problems are solved out. Now, when if the cells are very abnormal, as I told you, you need to have a hierarchical review. You can give it to your colleagues, experts who are slightly expert in that, and then discuss the cases, the cells. Show them and see the cells one by one and try to make a logical report out of that. So I think this is one thing. And then when you advise HPV DNA testing, like in a private practice, this facility is there. This is a very good way of correlating those cells with the HPV results of the HPV DNA. And another thing that I am doing in my practice is having a repeat smear after the infection has been treated. I couldn't put the pictures of the colposcopy cervix before and after treatment. It becomes very clean. Ask them to treat the patient, not to go for a pap smear immediately when she comes to you. If they, in practice, the patients do come back, so give them a good course of antibiotics, ask them to come after 2 to 3 months, and the cervix is very clean, and then you will get the proper cells for interpretation without a hindering background. So these are the features that you can follow at your end. This is in your control that you can do.
Yeah, thank you, ma'am. That was a very elaborate answer. Shruti has asked, could you, ma'am, please enlighten me on reflex testing? What does that mean?
Yes, now previously what was the norm that we had conventional smears, and then if you had doubtful cells, you had to call the patient all over again, collect the sample, and then do HPV DNA testing. Now the concept of reflex HPV DNA testing has come hand in hand with liquid-based cytology. That is one thing, because you are getting the material in a vial, in the fluid. That fluid remains in your lab. After you have prepared 1, 2, 3, 4 slides, you still have enough fluid remaining. So when you're seeing the smears and you find abnormal cells, immediately you order for a HPV DNA test. You don't have to call the patient again. So you are seeing some abnormal cells, you are unable to decide, you feel it is SQS, you order for a HPV DNA. So reflexly you tell the lab that please go in for a HPV DNA test in this patient. That is the concept. But it is happening only with LBC vials. With conventional smears, still I find it difficult. You have to call the patient all over again and then take a liquid sample in the thin prep vial or the show path vial and then do HPV test.
Thank you, ma'am.
Thank you.
Once again, thank you. Thank you very much, Dr. Kamal. Thanks to the whole team of KAHO who has been at the back of this. Our back-end office people also, Rabina and Sakshi, and there are so many of them sitting there. Thank you very much, KAHO office. Thank you, Preeti, and thank you, Aparna, for actually putting this together. It is such a nice topic and such a simple one, and something that everyone is looking at every day. And it really helps. I'm sure all the audience have been very much enriched by this presentation. And thank you to all the audience for being here and being with us, because without you, our webinars are nothing.